So you just confirm to me that you see the screen and my sound is okay.
Yes, it's clear, written LV and RV systolic function, Hatim Khirallah. And your
Very
picture also is clear.
good. So today we are gonna go, like we said, we have started already in the echo block. We started with introduction last week, and this is gonna be the second session in echo block. It's gonna be about LV and RV systolic function. The systolic function is gonna be in a separate session. So we'll start. There are some uh, concepts I would like to introduce you to. They have different importance. So I'm gonna stress on each one separately, give you the idea about it, and discuss together the importance of its acquisition and interpretation. This is a very important session about LV and RV systolic function. And this is the bread and butter of what we do in echo. The first thing is here, cardiac size and chest X-ray. This is how we evaluate cardiac size in chest X-ray by cardiothoracic ratio. And probably you have referral from primary care or internal medicine upon a chest X-ray showing cardiomegaly. And when you do echo, there is no cardiomegaly. Again, because, and I probably have alluded to that in a former session, that the heart we see in the chest X-ray is all of this, starting from here. So it includes the fat, the fluid, anything that surrounds the heart is seen here too. But the heart proper is just this one. So this is one of the reasons that chest X-ray might erroneously give a false impression of cardiomegaly. Added to this, the orientation of the chest X-ray has a lot to do with the cardiac silhouette and the cardiac size. So be careful about interpreting cardiomegaly in chest X-ray. Now, how we do evaluation of LV in echo? So I remind you that echo is one modality we have. We also have angiogram, we have nuclear, we have CT, we have MRI. In all of which we can get to evaluation of LV volumes and LV ejection fraction. But echo is and still is and is probably gonna be the cornerstone and the first line of diagnostics as to LV function. And usually, we reach a precise diagnosis as to LV function in echo, and usually, almost always, we don't need to go any further. Yani in few circumstances, we might go for cardiac CMR as Supreme Court to judge about ambiguous cases or have an additional information that's going to be helpful in decision making. Lakin usually echo settle almost all the details we need for decision making. When you are going to see a slide like this showing the different modalities we employ for LV evaluation, kind of linear measurement, volumetric measurement, stroke volume, Simpson with and without contrast, Doppler, 3D, and strain. As far as guidelines are concerned, they give you the evaluation in different... Sorry, can you be careful about the mics, please? Just mute, please. So the recommendation is linear dimension, assessment of LV function based on linear dimension by 2D and M mode. I'm gonna discuss that. Volumetric assessment by plane method, which is called Simpson method. We can sometimes use the contrast if the endocardial borders are not clear. So this contrast is going to enhance the endocardial border. There is 3D software for evaluation of LV function, 3D software. and there is also strain. Now let's start one by one, and I want you just to pay me attention and stop me in any point where you need further elaboration.
نعم الأول.
Just let me mute. So as you see here, this one, 2D, we get the LV in diastolic dimension, and then we scroll into a systolic frame and we get LV in systolic dimension. We can do that by 2D or by, like you see in here, sorry, back, by M mode. It's easy here, LV end diastolic and LV systolic dimension. Make sure that your line is perpendicular, because any obliquity is gonna make erroneous measurement, and that's gonna impact your evaluation. So it's easily like left ventricular end diastolic, left ventricular end systolic. Now, what is fractional shortening? Fractional shortening is LV end diastolic dimension minus LV end systolic dimension divided by the baseline, which is LV end diastolic dimension times 100. This gives the fractional shortening, okay? And the normal range of fractional shortening is 25–45%. Do you think the fractional shortening, the moment that you go in the machine and you drop your lines and you do the M mode and you just obtain end diastolic and end systolic dimension, the machine itself is going to give you the fractional shortening on this side, like this one here, fractional shortening, okay? Do you think the fractional shortening is an accurate measurement for LV systolic function? I'm waiting for your comment. What is the caveat of evaluating LV systolic function based on fractional shortening? No, it is just one dimension analysis. Okay, so it just evaluate this part and assuming this part is reflecting the entirety of the LV, which we don't see. And that might not be true, because LV systolic function might be impaired segmentally, not necessarily globally. It might be accurate in global hypokinesis, but not in regional wall motion abnormalities, because you might get normal fractional shortening here at the base, but in the mid and apical segments, you get severe hypokinesia, which is not picked by this single point analysis. Okay, so remember, fractional shortening has its shortcomings. We have MAPC, which is similar to TAPC. It is mitral annular plane systolic excursion. What we do here is simply, it's an M mode based measurement. So we put our cursor along the lateral annulus here, and we press on M mode, and here is what we get. We want to measure the height of systolic excursion of this segment. Again, the problem of fractional shortening applies to MAPC because it is single point analysis. It just analyzes this point and assume this point reflects the entirety of the LV. Again, this is a problem, okay? MAPC, the normal MAPC is 12 to 15 millimeter, while the TAPC, when we come to discuss TAPC, it is 17. So the lateral annulus of the RV is faster in velocity than the mitral annular velocity. Remember this. Now we have this concept, EPSS. This stands for E point to septal separation. So this is again an M-mode measurement. And how we get it? We drop our cursor intersecting the mitral valve and we press on M-mode, and here is what we get. Like we said in the former session, M-mode of the mitral valve is composed of E and A closure and opening, E and A closure and opening, E and A, and so on and so forth. So what is EPSS? EPSS is the distance between the E and the septum. Yeah, it's this distance between E point, septal separation. Okay, so as this point, as it decreases, meaning the ejection fraction is better. So this length, EPSS, is inversely proportional to the ejection fraction. Yes, you get the point here. If the LV is weak, like in here, look at this one. The LV is weak, so the point is lengthy. This distance is lengthy. But if the LV is normal or hypercontractile, the length between the E and septum is gonna shorten. Yes. So the normal one is like 7, more than 7, more than 8. Anything lower than 7 is considered abnormal. There are some studies that have actually, like this one, used EPSS to drive ejection fraction using this formula, 75 minus 5, sorry, 75.5 minus 2.5 times EPSS. It gives you the ejection fraction. Okay, again, this is not so accurate, but it's important we know that EPSS can also be used for rough estimation of the LV systolic function. Now we come to this one, which is called dP over dt. D is delta, delta pressure over delta time, delta pressure over delta time. What's the meaning of that? This means we take the MR signal, and most of the time we have MR, physiological MR. So we trace that MR, whether physiological or pathological. We trace it this way, and then we locate 2 points, one at 1 centimeter velocity and one at 3 centimeter velocity. Okay? And this 1 centimeter, 1 meter per second velocity correspond to what pressure? According to Bernoulli equation, 4V square, meaning 4 times V, which is 1 square, meaning 4. And here is 3. 3. What is the pressure that corresponds to 3 velocity? It is 4V square. 4 times 3 square, that is 36. So the pressure difference between this point and this point is 36 minus 4, which is 32. Then I'm going to measure this time. This time, you see this one here? This time. Let me explain it better. So I'm going to choose 2 points at 1 and at 3. This is the standardized points. This gives me a pressure difference between these 2 points of 32. My idea is, the idea here is, how much time I need to generate this 32 millimeter mercury. As the time gets shorter, means the LV systolic function is good. Yeah? يعني تخيلوا معي إنه كل ما كان ال LV strong معناته it can generate 32 millimeter mercury pressure difference in a shorter time. Right? وكل ما بقى weak معناته it can generate this pressure in a longer duration. So the issue is you divide this pressure by this time you obtain here, which is this time here, this time, okay? And I get figures like this one here. If it's more than 1200, it's normal. Severely reduced if it's less than 500 millimeter mercury per second. If, sorry, please mind your mics, please. And an easier way of doing it, look at this. If I give you this TR signal, this is a TR signal, okay? I give you another TR signal that looks like this, in which, sorry, not TR, MR. So this is MR signal and this is MR signal. So I want you to guess, based on this concept, in which of these two signals you think the LV is weak or weaker. It is in this signal. Because here, if I calculate the time from the start to the end is short time, meaning that the LV, what generates this velocity? What generates the velocity of the MR? The LV systolic contraction. So if I go from this point to this point in a shorter duration, means the LV is weak. But if I go from this point to the peak in a very long duration like this, meaning that the LV is weak. Yeah. So this is the concept of dP over dt, delta pressure over delta time. Now we come to the most important part of echo evaluation of LV systolic function, which is the ejection fraction. Okay. And last time we hear about the word of eyeballing, meaning that you just look at the LV contractility and you estimate the ejection fraction based on your experience, okay? But this needs kind of experience and it might not be so accurate and there are some subjectivities, okay? So the best way to evaluate ejection fraction is by Simpson or biplane modified method. First of all, let's understand what ejection fraction means. Ejection fraction is end diastolic volume minus end systolic volume divided by end diastolic volume percent. Okay? So what I need is, I need two volumes, end diastolic volume and end systolic volume. How I get these volumes? In the machine, there is software, biplane method or Simpson method software is built in all echo machines, and you just have to go into 4-chamber and 2-chamber. So you take the 4-chamber like this, okay, and the 2-chamber like this here. These are the 2-chamber, and here are the 4-chamber. Then you go for the diastolic frame. How you decide about the diastolic frame? You keep scrolling until you get the widest volume or the widest dimension of the LV. And then you trace it, you trace the endocardial border by the software, you trace it this way. And then you click end. The moment you click end, a volume is gonna get here. So there is a volume, okay? Now we come to the same apical 4 and we scroll until we get the narrowest diameter or the smallest volume. This is the systolic frame, and I do the same. I track the endocardial border and click finish. The moment I click finish, I get a volume here, which is the end systolic volume. And I do the same with the apical 2. So now I have a diastolic volume and I have the systolic volume, so I can get ejection fraction reasonably objectively, not like eyeballing. Yeah. But the problem with this method is what? Can you tell me? Is it easy or hard? or
The
the
endocardial border, Dr. Hatim, sometimes
exact.
difficult to delineate endocardial border.
Very good, Yasin.
Yeah.
This is one problem. The problem is the definition of the endocardial border might not be clear on all studies. Okay. And the other thing, the definition of systolic and diastolic frame sometime might be a problem. So you have to make sure that you are in the end diastolic and end systolic. Okay. Yeah. So these are the problem of Simpson. Now, if we have a problem of endocardial border, which is not clear, is there any way we can work around this or do some kind of working around this problem?
Yeah,
Anything?
contrast, yeah. Inject contrast.
Exactly. So we can inject contrast, okay? Look at it here. And by the injection of the contrast, the endocardial border are now well delineated. So the hypothesis that you might need to make in here is no longer here because the endocardial border is so clear, okay? So we use contrast. This is called ultrasound enhancing contrast agent, okay? Ultrasound enhancing agent. It's not the saline, agitated saline, that's a different one. We are talking about ultrasound enhancing agent. And the one in the market, the most commonly used are three: Optizone, Sonoview, and Definity. It's given IV, and we are going to have a dedicated lecture or session about contrast echo later on. Remember last session we said that the contrast can also be used to look for apical pathologies because the apex sometimes, like in this here, is not so visible. But when we give contrast, we see kind of recesses and trabeculation, non-compaction. Here, the apex was not clear, but when we give the contrast, we see thrombi, two thrombi here in the apex. So it's important sometimes to give contrast. So contrast is important to objectify the assessment of ejection fraction and to disclose apical pathologies which are not clear on plain echo. Okay. Now, what are the normal values of ejection fraction? The normal value, look at it here. Male, 52 to 72%. Female, 54 to 74. Remind you, the ejection fraction of women is higher than in men. Okay? You see the range? It's higher in women than in men. Okay? Now, severely abnormal, what we call now, when we talk about LV systolic function, we say that it is mildly impaired or moderately impaired or severely impaired. That is based on the ejection fraction. So what mildly impaired means in terms of ejection fraction? What does it mean? Meaning more than 45. Moderately impaired means more than 35. Severely impaired is anything lower than 35. Okay? Percent ejection fraction. Now, ejection fraction is important because we know that heart failure phenotypes are divided into three based on ejection fraction, right? Heart failure with reduced ejection fraction, when the ejection fraction is equal to or less than 40. Heart failure with preserved ejection fraction, when ejection fraction is equal to or more than 50. And heart failure with mildly reduced ejection fraction in between. Okay. Another important terminology you should familiarize yourself with when you are describing regional wall motion abnormality or the contractility. There is a normal contractility, there is hypokinesis, akinesis, dyskinesis, and aneurysmal dilatation. Sometimes we add it, okay? So what does it mean to have hypokinesis? What does it mean? Hypokinesis, simply it means it's contracting, but to a weaker extent. How do we know weaker extent? What do we mean by weaker extent? Weaker extent means the thickening of this segment is between 10 to 30%. The normal thickening is more than 30%. Yani the segment, if this segment is like this, when it contracts, it goes like this. So if you compare this one to this one, how much it change, it is more than 30% increase in thickening. But hypokinesis is less than 30%. Akinesis when there is no contractility at all. So the segments in systole, in diastole, and in systole is the same length, it does not thicken. Dyskinesis is paradoxical motion. Paradoxical, meaning in systole, usually in systole it gets thick, in diastole it gets thin, it gets stretched out, right? That's the normal thing. Any segment thicken during systole and stretch during diastole. Now in dyskinesis, the opposite happens. In systole, it bulges out. In diastole, it comes in. Okay, so this is a stage of severe akinesis with dyskinesis. So now, remember, we have hypokinesis, we have akinesis, we have dyskinesis. Okay? And this is the segmentation model we have alluded to last session. Okay, we have 17 segments. 17 segments. Okay, and these segments, we see them like here in the apical 4. This is apical 4. What do we see in the apical 4? What is this segment here? What is this? Lateral segment. What is this septum here? Inferior septum. What is this segment in the 2 chamber? This one, all is anterior. What is this segment or wall? This wall is what? Inferior. Then it is divided into basal, mid, and apical. But all of it is called anterior. And this is inferior. This is lateral, and this is inferior septum. And this is anterior septum, and this is inferior lateral. Yes? When we come to the short axis, it might be more informative because the short axis is sliced across 3 levels like we discussed last time. Basal level, mid-level, and apical level. Here we have 6 segments, here 6 segments, and here 4 segments, total of 16 segments. Along with the apical cap, which is here, this makes the 17th model segmentation of the LV. So again, let's revise this one here. Anterior segment, anterolateral, inferior, inferior septum, anterior septum. The same in the mid cavity. While we come at the apex, we just have anterior, lateral, inferior, and septal. Okay? So how do you describe the segment? Like if I get this one here, there is hypokinesis in this one. How you describe it? You say there is hypokinesis of the basal anterior segment. Hypokinesis of the basal anterior segment. طيب, if there is also hypokinesis here, then you are going to describe there is hypokinesis of the basal and mid anterior segment. Okay, and you go on detailing the segments that are involved in hypokinesis or akinesis. Okay, this is important because, like we said, it corresponds to the coronary artery distribution. This is called the bull's eye. Again, these are the 17 segments. The segments on here, the green colored segments, are supplied by the CERC. These are supplied by the RCA, and these are supplied by the LAD. So if I take you back here, this one here is LAD, this one here is RCA, and this one here, sorry, this one here is CERC, and this one last here is RCA. Okay? So far, so good?
Yes, it's fine.
تمام. Now we come to the stroke volume. What do we mean by stroke volume and cardiac output? طيب. Stroke volume is also important to get in echo, but the way we get it is a bit tedious, and we are going to talk about it when we discuss echo hemodynamics, because it needs measuring area and the TVI. But anyhow, as far as this presentation is concerned, just know that we can measure the stroke volume and the cardiac output from echo this way, okay? And the difference between the cardiac output and the stroke volume is that the cardiac output is stroke volume times heart rate, okay? That's it. Now, what is strain? Because you heard about this a lot probably. Just a moment. Just a moment, guys. Sorry. Sorry, do you see it again? Do you see the slides?
Yes, it's
Yeah,
clear.
Okay. So here is the strain. What do we mean by strain? And what is the relationship between strain and ejection fraction? And how much we use strain routinely in echo? Honestly speaking, is not routine, but it's important. And as the technology advances, it might be the standard way of measurement of ejection fraction or of LV systolic function, okay? Now, when we look at the heart and we slice the heart, we are going to see that the heart is having 3 muscular layers, okay? The endocardial layer is longitudinal muscles. Mid-wall is circular layer of muscles. And the epicardium, which is the uppermost layer, is oblique muscles, okay? This longitudinal muscle result in, if you see my video, if you see my hands, it leads to the contraction from base to the apex. It contracts this way, okay? Now, this muscle leads to contraction in a radial plane like this, okay? And this muscle leads to twisting and untwisting. So the heart mechanics is not as simple as we thought it is, just this. No, it contracts in 3 planes. This way, top down, twisting and untwisting, okay? So this has given insight into the fact that ejection fraction might be underestimating the LV systolic function, and strain might be a better marker of LV systolic function. So from these 3, they have chosen this one because it's the easiest to measure longitudinal strain. So the one that is most clinically used is longitudinal strain. Not radial, not circumferential. Although there are some studies about validity of these strains, but the clinically used one, commonly used one, is the longitudinal strain, which is here, okay? So it is how the heart deform in this axis, top down, called longitudinal strain. And here we get the strain. We get it in form of graphs. Each segment has a curve, and we also have it summed up in this polar map circle or bullseye circle. Now look at this look at this, for example. Here, the ejection fraction is 50%. Ejection fraction is 50%. But look here, the global longitudinal strain is minus 18%, and here is minus 13%. This emphasizes the fact that strain is better evaluator of LV systolic function than ejection fraction. So many times, you analyze the ejection fraction and it's normal, you do the strain and it is abnormal. Yes? So strain gives better idea, more accurate idea, an earlier idea about LV systolic dysfunction than ejection fraction. Again, here is strain in chemotherapy, which is used commonly. This is a patient who was taking anthracycline, and here is the strain after few cycles. Now it start to change and become weaker. So they treated that, and here is the final result after the treatment. In all these phases, the ejection fraction was the same. It doesn't drop. Okay, just a moment. طيب سوري شباب معاي ولا I get you bored already؟
موجودين يا بص.
تمام. طيب يعني يا شباب بس ببساطة جدا strain ممكن في المستقبل القريب to replace ejection fraction لأنه لاحظنا إنه it's more accurate and it gets LV dysfunction earlier. تمام؟ يعني في أحيان كثيرة زي ما قلت لكم بنلاحظ إنه الإجكشن fraction is normal لكن الstrain is abnormal. Then we wait for some time, the ejection fraction drops. That means the strain has been capable of getting LV systolic dysfunction earlier. ولأنه simply the idea of the strain is definitely smarter than the idea of ejection fraction. لأن it analyzes the cardiac mechanics in 3 different planes instead of just the radial contractility, which is oversimplification of the actual LV systolic function. Okay? Tamam. Now I want your participation here. What do you think about this? This is parasternal long axis, and this is short axis. So what do you think about the LV systolic function? So all the segments are thickening. And the amount of thickening is more than 30%. So this is normal ejection fraction. Now look at this one here. What do you think? The image quality is not so good. But we can appreciate that the heart is what? hyperdynamic. Hyperdynamic. Yes. Now look here. This is what? Apical 4, apical 2, apical 3, right? Apical 4, apical 2, apical 3. What is this wall here? Lateral wall. Inferior septum, apex. What is here? Anterior wall, inferior wall, and apex. What is here? Anterior septum, inferolateral, and apex. Yeah, so we can analyze the segmental motion based on this. But here, this is normal contractility. What about this? What do you think about this?
Global.
Exactly, global. First, the LV is dilated appreciably. And do you think this is hypokinesis or akinesis or dyskinesis?
Dyskinesis.
لا dyskinesis دي بتقوليها في حالة
هايبو
واحدة.
هايبو it's
أيوة
hypokinetic.
severe
severe
hypokinesis.
hypokinesis exactly. يعني ممكن كان أنا أقبل منك تقولي لي akinesis maybe here مثلا it is hypo but here it's akinetic. I might accept that. لكن dyskinesis you just reserve it when you see a segment that contracts in the opposite direction. During systole, it stretches out. During diastole, it goes in. Yeah? So this is a different scenario. طيب, what do you think about this? Apical 4, apical 2, and apical 3.
Akinesis.
Yes, you're right.
Yeah, it is akinetic in the apex and
Again, it is severely hypokinetic globally. Yes. So this is severe LV systolic dysfunction. Ejection fraction, if it's traced by Simpson method, which is biplane disc method we have discussed earlier, is going to be in the range of 25 to 30%. Severe LV dysfunction. Now tell me about this. What are we seeing here?
LVH, severe LVH, and
Okay.
LVO2 obstruction.
Okay, but very hard to decide about LV obstruction based on a single view like this.
Hypokinesia.
Where the hypokinesia is?
It is anterior
Very good. Very good.
yeah.
Yes. Yes. You look at this segment, this is inferolateral segment, and this is the anterior septum. Look at the anterior septum. Is severely hypokinetic. Again here, you look at this part, compare it with this part. Yes? Anterior and anterior septum are hypokinetic compared to these segments. So this is LAD infarction or LAD ischemia, accurately speaking. What is this? This is apical.
This kinetic apex.
This kinetic now.
Okay, you can say that. Here the apex, yes. And also what else? The anterior wall, anterior septum, the anterior septum. It's what? It is akinetic. It's not thickening at all, you see?
Yeah.
It's akinetic. So now we know how hypokinesis looks like, how akinesis looks like. Yes? Good? Right. What do we have here? Apical 4 chamber. What do we have? What is this wall? Lateral wall. What is this? Apex. What is this? Inferior septum. So, or maybe anterior septum because the aorta is a bit open. But let's say this is inferior septum. So what do we see? The lateral wall is contracting, right? So look at
Yeah.
it. Yes, it's contracting this part. The apex is akinetic,
Kinetic and the septum.
and the septum is akinetic, and there is a probability of LV apical thrombus here. Yes. Now, what do you think here? This is apical two-chamber view. In apical two-chamber view, we see two walls, anterior on this side, inferior on this side, and the apex here. So which one is hypokinetic?
Anterior.
Exactly. No, you are right. You were right.
The inferior is akinetic, isn't
the
it?
inferior is hypokinetic. So this is inferior ischemia. And what do we have here? Parasternal long axis and short axis. This short axis view is at which level? The level of papillary muscle cavity level, yes? So what's your interpretation of the regionality here?
Inferior wall hypokinesia, short axis.
Okay, hypokinesis where?
Inferior.
Very good. Very good. So you see, it is here.
Yes.
So it is in the inferolateral and the inferior. And also when you look in here, this is the anterior septum, and look at this wall in comparison to the contractility here, it's hypokinetic. Yes.
Posterior.
Very good. And what do we see here? Apical four chamber.
Big LV thrombus.
And before that, before the thrombus, how about the
Apical
motion
cap
abnormality?
akinesia. Apical cap
Anterior
akinesia.
septum.
Exactly. So the apex here is akinetic, and there is large apical thrombus. And here, what do we have? This is, you know, it's a bit strange. You say this is apical 2 and this is apical 4. What we are seeing here is from mid segment downward, we have no contractility, i.e. akinesis. Again here, this is the basal lateral wall. It's contracting, but the mid and apical part is not. Here, the inferior septum base is contracting, but the mid and downward is not. This was a case of stress-induced cardiomyopathy, Takotsubo syndrome, heartbroken syndrome, okay? And this is severe hypokinesis, which is global, and again with LV apical thrombus. Now, this complication, that's a question to you, is more common in the acute stage of STEMI than the late remodeling stage. I want you to choose the right answer. Most likely associated with visible, dense, spontaneous contrast. One of the indication for the use of direct oral anticoagulant, MR increases its incidence. So which one you think is the right answer?
When is the indication of more?
Sorry?
Number one, I think, more common in
Number
acute.
one. Just a moment. Just a moment. يا شباب, sorry to put you on wait. طيب.
No problem.
Now we said this is an LV thrombus and the LV is severely hypokinetic globally. The question was about it is more common in the acute stage of STEMI, meaning the LV thrombus. Is it more common in the early stage or the late stage? And is it associated with visible dense spontaneous contrast? Is it indication for NOAC? And does MR increase its incidence? So what do you think? What do you think?
Can I change my mind?
You change your mind. So which one you have
Most
chosen?
likely associated with visible contrast.
Yes.
الكلام الأول ما بيتحول يا سارة. I think
والله
more
الأول
acute
الأول ما المفروض
stage.
ما يتحول لكن ما أعرف كيف.
طيب, here the dense spontaneous contrast.
And I think it's associated with the severe mitral.
MR. طيب, let's start with the MR. If we have MR coming and going into the LV, coming and going out of the LV, in fact, it decreases its incidence. لأنه the MR is kind of washes out the stasis. Okay? So the incidence is lower if we have moderate to severe MR. Okay? And of course, NOAC can be used, but it's off-label use. Yeah? Here, it's warfarin, not NOAC, though we are starting to use it with great efficacy with LV epica thrombi. And most of the time, there is no visible contrast. But if there is visible contrast, yes, طبعا لما يكون في visible contrast, it makes it more likely. لكن usually we don't see that. It is more common in the acute stage of STEMI than the late remodeling stage. يعني الآن أنت إذا شفت الSTEMI weeks after STEMI, this is the time of LV epica thrombus. لكن months, 2 years after STEMI, unlikely. Yes? So it's more common in the acute stage. Now, this complication, as you see here, this is an apical 4-chamber, and you see the apex is akinetic, and the septum is akinetic and aneurysmal. And there is flow going through the septum. So the diagnosis here is what?
VSR.
VSR.
Exactly, this is ventricular septal rupture. So the question was, choose the right answer. Associated with soft murmur, occurs 3 to 4 weeks after onset of MI. It doesn't occur with non-STEMI. Earlier surgery is associated with high success rate. Intra-aortic balloon pump is vital temporary hemodynamic support. So, which one you think is right?
So it is usually with harsh murmur, and it's occurred 3 to 4 days after MI.
Exactly. So the murmur of VSR is not like the murmur of MR due to papillary muscle rupture. It is loud, intense, and associated with thrill. So number 1 is wrong.
Was the early surgery associated with high success rate?
Okay. Good.
I don't think so.
This is wrong also.
Yeah, this is wrong also. So it could be EAP, and also it could be, I don't know if it doesn't occur with non-STEMI. So it maybe it doesn't occur with non-STEMI. This is the correct answer.
Yeah, here it is more common with STEMI, but it can occur with non-STEMI as well. Yes? It can.
Okay. Okay.
Does it occur
yeah,
3 to
it's
4 weeks?
vitally temporary.
Does it occur 3 to 4 weeks after onset of MI?
3 to 4 days instead.
Exactly, 3 to 4 days. So this is wrong. So now, خلاص, I think you have reached the answer. So this is not right, this is not right, this is not right. So we are between these two. And by the way, earlier surgery, the success rate of VSR is not high.
Yeah, it is low.
Not earlier, not late. You know, لأنه the necrotic tissue is very friable,
Friable.
so it doesn't hold the patch, okay? So it is hard no matter how early you intervene. But usually for mechanical complication, you need some kind of mechanical support, and we start with intra-aortic balloon pump, okay? Good. Now for the septal measurement, طبعا it's important also as part of LV quantification is the thickness of the muscle. So we look in here, we see the thickness, LV thickness. Do we check this thickness in systole or in diastole?
Diastole.
Diastole, yeah.
Diastole, exactly. Type. And now I gave you 3 measurements. This one, and the yellow one, and the red one. Which one is the most accurate?
It should be in mid-septum.
Yes,
Yeah.
so here. Okay. So you have to make sure that you are dropping kind of perpendicular line. And the other thing is that make sure that you are not including part of the RV trabeculation, like in here. This part here, this part belongs to RV. Yes. So it's included in the measurement. And don't go too deep. It's in the basal septum, okay? So if you have a problem in here, you can use the short axis, because the short axis can eliminate the trabeculation coming from the RV. So the LV thickness isn't always easy, and you have to be mindful of this caveat in the measurement, okay? Including RV trabeculation or choosing the wrong point or being too oblique, all these things, okay? And look at it here. Now, if this is RV trabeculation, so if you drop the line like this, you have included part of the RV. So you have to be careful. This is the right one. And also here, you have to, in the posterior wall, this is the thickness.
I
If you
can't
go,
see any cursor. Are you marking with
really?
your... Yeah.
You don't see the red pen? You don't see the
now
red
I
pen?
see it, but
Yeah,
يعني
yes.
قبل شوي مش شايفة حاجة والله. ما
Okay.
عارفة يمكن أنا.
So here, this is the posterior wall. So if you take it from here and go all the way like this, you have included part of the papillary muscle. So you have to take the papillary muscle out and make sure that you are not including it. So it isn't always easy. And when you have a sigmoid septum like this, exclude the sigmoid part and go a bit distal, okay? So these all, yes. Now, the other thing that when you take apical, if you are working technically in acquisition, you know that the apical window isn't easy, because sometimes you get the LV foreshortened. And foreshortened sometimes can be very excessive foreshortening, as the LV appears kind of globular. The LV should be kind of bullet shaped like this. It has to be bullet shaped. If it start to get rounded, means you are foreshortening, and you have to reorient your probe to eliminate this foreshortening. And one rule of thumb to know that if you are foreshortening or not, look at the apex here, the LV apex. This is the LV apex. Where is the RV apex? It's here. This is the RV apex. So usually the most distal part is the LV apex. But look here. Where is the LV apex? Here. Where is the RV apex? Here. So if they are close, meaning that you are foreshortening the LV. So to make sure that your LV is stretched out nicely and is not foreshortened, make sure that the LV apex is distal, more distal than the RV apex. If you see that, معناته you are sure that you are not foreshortening. Okay. Now for the RV, طبعا RV is a harder chamber to quantify than LV. There are something that makes it harder, some other things makes it easier. The geometry of the LV is a bit complex. Yeah. So look at it here. So, and according to the cut, you might come across it in a different orientation and you get different images. Like now this is apical 4, apical 4, apical 4. And each one you might feel that the RV dimension is different. That's why our fellows get lost in RV quantification more than they do with LV quantification, especially as to the size. لأنه الcut might give erroneous idea of LV dilatation and stuff like that. So we have to make sure that our cut is oriented right. Now we come to TAPSE. TAPSE is a very important concept you have to know so well about. TAPSE stands for tricuspid annular plane systolic excursion. That reminds us of what? Of MAPSE. MAPSE, we don't use it. Commonly, we don't use it. Routinely, we don't use it. But TAPSE, we use it routinely for each and every case. Okay? So what is TAPSE? TAPSE is simply, you choose this point here. This is the tricuspid valve. You choose the lateral annulus, and you drop your cursor along it, and you click on M mode. So that's what you get. You get these peaks. So what is TAPSE? TAPSE is from the nadir to the peak of the systolic excursion. This length is TAPSE. How much it should be? Should be more than 17 millimeter, more than 1.7 centimeter. If it is less than that, meaning that the RV, there is RV systolic dysfunction. Okay? So assure me that you have understood TAPSE so well, and it's so important. It's reproducible, it's easy to obtain, it's easy to interpret, and it is very well validated in studies, okay? So this is TAPSE, okay? So we have another concept, which is TDI, and TDI stands for tissue Doppler imaging. So when you see things like that, this is TDI, okay? Because it's based on color Doppler, TDI, okay? So it uses two, color Doppler and PW. So what you have to do is in the machine itself, there is TDI. You press on TDI and you put your cursor where you wanna get the TDI from. And then you click on PW after you specify a point. So PW is gonna specify the point. So if your point is here, if you have chosen this point and you click on PW, here is what you get. Okay, this is what you get. This is a TDI signal. So what does this stands for? S, E prime, and A prime. Why do we call them E prime and A prime? To distinguish them from E and A of the mitral inflow. In the mitral inflow, we have E and A, E and A. This is named E prime and A prime عشان تعرف أنه it is not E and A of the mitral inflow. لكنهم هم نفسهم. It's due to the same mechanics, yeah? E prime and A prime. So it is about the mechanics of this point. So it's analyzed mechanically. So this point contracts. When it contracts, where it goes? It goes here towards this, towards the probe. So we get S prime. When it relaxes twice. During the early phase, E prime, and during the late phase, A prime. Yes? So we have S prime, E prime, and A prime. What does this have to do with RV systolic function? Because we can assess TDI of the same point we assess with TAPSE. You know TAPSE? Here. TAPSE, we take this point, right? Lateral to mitral to tricuspid valve. Now for the TDI of the RV, we also take the same point, but instead of M mode, we choose TDI PW, and here is what we get. And this is the S prime. What's the meaning of S prime? Is the peak of systolic contraction. So if it is lower than 9.5, meaning that the RV is weak. It has to be more than 10. If it is less than 9.5, meaning the RV is weak. So TDIS prime is another way of evaluating RV systolic function. Now, how do we evaluate RV systolic thickness? لاحظ ال LV systolic thickness, we assess it where? From the parasternal long axis or the short axis. Now, RV systolic thickness from the subcostal window where the liver is in here. The liver and here is. And just below the tricuspid valve, we choose a diastolic frame and we check the thickness in diastole. Usually, more than 5 is considered abnormal. More than 5 millimeter. لأنه ال RV طبعا in LV more than 1.1 is considered hypertrophy. In RV more than 0.5 is considered hypertrophy. See the difference? Yes, that's expected difference لأنه ال LV أصلا normally is more muscular than the RV. Okay? تمام. Now we also for the RV we take measurement. And we take measurement at different places. Why do we do that? لأنه زي ما اتفقنا إنه الجيومتري بتاع ال RV is a bit tricky. Yeah? So we have to make sure. And we have to eliminate error in measurement by measuring in different locations and orientation. That's why we choose the apical 4 and short axis and parasternal. In the parasternal, we check here. In the short axis, we check the RVOT. And in the apical, we check the base and the mid. Okay? Good. And these are the normal figures. Less than 35 here. Okay? And less than 35 in the mid and less than 41 millimeter at the base of the apical 4 chamber. Type. Tell me, what do you see in here?
RV pressure overload.
Yeah, so we have RV. This is LV short axis with RV here. The LV is contracting well. Here there is precardial effusion in the last image here. Okay, like in the most important thing here is the dilated RV.
Dilated RV.
In all of them. This is mildly dilated, this is moderately dilated, this is severely dilated. And look at the septum. It is flattened here, it is more flattened here, it is very flattened here. Yes, so flattening of the septum, sometimes they call it
D-shape.
D-shape or D-sign. Sometimes they call it D-sign, or sometimes they call it D-shaped what? D-shaped what? Septum? Huh? Do you call it D-shaped septum?
D-shaped LV.
Exactly, yes. ده واحد من الميستيكس. الناس بيقولوا D-shaped septum. No, the septum is not D-shaped. What is D-shaped is the LV, bigger D-shaped. So it is D-shaped septum, or you can just say flat septum or flattened septum. Okay? Or D-sign. And here is eccentricity index. The eccentricity index is measuring two orthogonal planes like this, D1 and D2. It divides D2 by D1. D2 is here, and D1 is here. And usually it is 1 or less than 1 because they are diameter and this is a circle. But if there is D-shaped LV, now D2 is going to be more than D1 and the eccentricity index is going to be more than 1. Okay? And we have to remember that if we have pressure overload, we get a flat septum in systole and in diastole, but it's more in systole. And when we have volume overload, we get D-shaped septum during diastole. This is important distinction between pressure overload D-shaped sign and volume overload D-shaped LV, okay? So remember this. Again, if you have pressure overload, the septum is going to be flat in systole and in diastole, but more in systole than in diastole. But if you have volume overload, it is diastolic flattening of the septum. Okay? Now tell me, what do you see here? The image quality isn't so good, but try your best. Look at the LV, RV. RV is weak, except here.
Kinetic septal and hyperkinetic
PE.
Exactly. Yeah,
O'Neill sign.
exactly. So the
Yes.
apex of the RV is contracting, but the free wall is not. And even if you look here, when we go toward the apex, we appreciate hypercontractility, but hypokinesis, free wall. So this is McConnell sign of pulmonary embolism. Okay? So by this, we come to the end of this presentation, and thank you so much. Most important about this presentation, the thing that you should know, and the most important takeaways is the Simpson method, volumetric assessment of the ejection fraction, okay? The one we have discussed earlier. This one, yes? This is the most important thing because this is employed routinely for all cases. And we have to be objective about ejection fraction because eyeballing of the ejection fraction needs experience, needs feel lots of subjectivity, so it might be erroneous, you know. And sometimes you need to tell exactly what the ejection fraction is. لأنه إذا أنت مثلا by eyeballing قلت the ejection fraction is 50 and the patient was on chemotherapy and it was 60 before, معناتها مصير هذا البيشنت كله تغير بكلامك ده لأنه حيوقفوا الكيموثيرابي. Okay? If you want to put an ICD and you said that the ejection fraction is 40 وهو 34, ما حيخطوا ال ICD and the patient might die just because of your wrong evaluation. So make sure that the ejection fraction is make or break in decision making, so we have to be objectively accurate about its assessment. And the best way to go is Simpson method, biplane disc method, okay? And sometimes the use of contrast and the segmentations are important, the 17 segmentation and how we see them in different orientation, like I have showed you, which in each and every view you see in echo, you know what are the segments are here. Like we said last time, in 2D echo, you can never see the heart in its entirety in a single image, never at all. يعني هنا الآن, do we see the entire heart? No, we see part of it. We see slice. Here we see slice. Here we see slice. Here we see slice, slice. Yeah? So it is slices. That's why in each slice, you have to know what segments you are seeing in this particular slice. So we know here, this is the anterior septum. This is the inferolateral. Here is the anterior wall, the lateral wall, inferolateral, inferior, septum. So you have to know exactly in each orientation what segments you are seeing to do the analysis based on normal, hypokinetic, akinetic, or dyskinetic. Okay? So this is the most important thing I would like to reiterate. Otherwise, I think we have just discussed things more than what is needed. أنا طبعا بالنسبة للمابسي والDP over DT, it's just important to know, but don't employ practically because they are not so common ways of assessment. Okay? And for RV, it's important to know the TAPC. TAPC. Okay? It's very important. Otherwise, things are just like we have discussed. Now I open the gate for any questions, any comments from you.
Thank you, Dr. Hatim, for this very rich and informative lectures. We have one of our senior also with us, Dr. الطيب محمد أحمد. تفضل دكتور الطيب.
Thanks, Dr. Hatim, for this very illustrative and very informative lecture. You make the difficult issues regarding the echo very simple and very easy. We thank you very much. I have one question. Is eyeballing will affect the ejection fraction positive or negative? I mean, by eyeballing alone, will you overestimate the ejection fraction or underestimate the ejection fraction? Usually, yeah. Thank you.
Thank you so much, Dr. حقيقة we are so honored إنك you are with us. And طيب بالنسبة للآي بولينج will it underestimate or overestimate the ejection fraction؟ نحن حقيقة we have done a study of 150 cases, okay, evaluated ejection fraction by eyeballing, and then for all the 150 cases, we did Simpson. And in some few cases, we did contrast, okay? What we found that is eyeballing underestimates the ejection fraction. Yani when we do Simpson, the ejection fraction is +7 to 10 sometimes. Like in the average was around تقريبا 5 to 7%. 5 to 7% sometimes has a robust impact on decision making. Sometimes is not. Okay? Like the margin wasn't so wide, but still 5-7 might also be important difference. When we come to the use of contrast, كمان we find that the contrast even gives additional increment to ejection fraction than when evaluated by plain Simpson. Okay? And this is if you go across the literature, you find this dilemma. If you evaluate ejection fraction by eyeballing versus by Simpson versus by contrast, okay? But the one that is clear, the gold standard of LV volume assessment and ejection fraction is CMR. So when they have compared the three or any other modalities of ejection fraction evaluation with MR, they found that Simpson is the best validated as far as CMR is concerned. That's why we cannot say that Simpson overestimate or underestimate. We say that Simpson so far is the most accurate way of evaluating the ejection fraction. Contrast overestimate, eyeballing underestimate. Okay.
Sorry, the second question is 3D or 4D echo position regarding the assessment of the LV systolic function. What is their position? Is it comparable to cardiac MR or less sensitive than cardiac MR, or what is the position of
Yeah,
3D imaging?
Yes, 3D echo based on transthoracic echo has lots of problems. Okay, طبعا as far as clinical trials and studies and core labs literature are concerned, they say that 3D evaluation of ejection fraction is as accurate as MRI. Okay, but honestly speaking, when we try to do 3D in our labs, we fail to get the good delineation and the good framework, and image quality will not help us to get that nice images within the literature. So the reproducibility is a problem. Yes, it might be accurate. Here, the accuracy is one measure of clinical uptake. We need an accurate measurement, but also we need reproducibility, meaning I can do it, you can do it, somebody in UK can do it, all we can do it equally and similarly with the machines we have. Now 3D is a problem. 3D, no, we fail to do it as accurate as the core labs in Mayo Clinic. Yes, so that's the problem of 3D. لذلك we don't routinely use it, and when we try to use it, we can't get the images that we are aiming at. Okay.
Okay, thank you very much, Dr. Hatim. Thank you very much.
Doctor. Thank you so much.
دكتورة نفيسة, can you comment?
Thank you, Dr. Hatim. It is great to be here. I don't think I will just say that CMR is the gold standard for volumetric assessment for LV and RV, especially the RV. But still the gold standard imaging in cardiography is still the echocardiogram. And so you have, for any cardiologist, have to master echocardiogram. Thank you.
شكرا يا دكتورة نفيسة، ده تواضع من عندك. طبعا احنا we say that CMR is the Supreme Court in Cardiology، المحكمة العليا. when we get stuck مع أي ambiguity in a lower level of imaging, we go for CMR, yeah, because CMR is more objective, it's software related. يعني الالتراساوند مهما سوينا فيها it's operator dependent. It's about how the technician do the study, how the patient image quality is, his echogenicity, the measurement, the alignment, and then the interpretation. Things are different شوية. ولذلك we might get lost. لكن hopefully or luckily, most of the time we can do the diagnosis at echo level. Most of the time, I would say, in the vast majority of the cases, لكن sometimes we need CMR to settle some disputes or ambiguities we encounter in echo sometimes.
Thank you, Dr. Hatim. The floors for the attendees, يعني, who want to comment, you can comment. Some of our seniors were there also, Dr. Haifa and